Okay, I'd like to welcome you all to the POOIA session, a monthly lecture series. Uh, okay, we have a distinguished speaker tonight that I'm going to try to introduce her. Dr. Karen Scoles, MD, is a graduate of Skidmore College and the Rutgers Medical School. She completed her residency in internal medicine at Thomas Jefferson University Hospital. She's board certified for internal medicine and clinical informatics. That's very interesting, informatics. It's getting close to computer and IT. She has practiced internal medicine for over 40 years with a focus on prevention, wellness, and women's health. She has had leadership positions in clinical information systems at multiple organizations with an emphasis on optimal use of information technology in clinical settings. Recently retired, she's enjoying more time to volunteer, travel, cycle, play tennis, and pickleball. Like on behalf of POOIA and the Persian and the Persian Cultural Center, I would like to thank you deeply for accepting our invitation, Dr. Scoles, and we anxiously look forward to your.
Thank you so much for having me. It's really an honor to speak before such an esteemed group of professionals, and it is very comforting to have friends in the group. So that is really helpful, and I appreciate Camelia and Comby's invitation, and I hope that the talk will be helpful and that we'll have time for questions. So let me share my screen and be well and thrive. So what I want to accomplish tonight is to give you some tips on, achieving and maintaining a healthy lifestyle. And, whether you have, no medical issues or chronic conditions, I think it's really possible to live your best life and to age well. And that's really what the focus of the talk is going to be. So I love the spring, and really for me, the new year is not January, or it really is spring. So today it's March, and I am so happy that spring is here. And I think that spring is a great time for new beginnings and a reboot, even more so than all of the opportunities that some of us try to take advantage of at the new year in terms of resolutions. I think this is a better time of the year to stick to new plans, and who cannot enjoy beautiful weather and the sun shining more during the day. So getting and staying healthy, really, it takes work. Some of us are blessed with incredible genes and sort of have no issues through life, but most of us are going to have some health issues that may or may not be symptomatic, that may or may not shorten our life. And, but many of these things are able to be positively influenced by lifestyle changes and other choices we can make. I always tell the story about my mother-in-law, Kevin's mother. She's now 98. And somehow she got there on a steady diet of doers and cigarettes. Clearly, there's some genetic, factors that we haven't identified yet about who does this. Most of us, have to, live a healthier lifestyle to get to 98. So I know that this is a busy slide, but these are sort of key points on, I think, what is really important. The primary importance is a healthy diet. And, many of us were fortunate to be raised in a culture that really was based on the Mediterranean type diet. And that, I think, will serve us all well. There's a lot of evidence to show that a healthy diet can really reduce inflammation, which is what can cause tissue damage and damage to our joints and arteries and organs. And I always used to tell patients that in terms of the next bullet, going easy on processed foods, is to try to eat foods that your great-grandparents would recognize as food. And that does not include Doritos or Twix or some of the processed foods that we eat. High blood sugar is absolutely linked to the development of diabetes, obesity, heart disease, and likely dementia. Physical activity is key, and we're going to talk a little bit about that. Definitely can reduce your risk of heart disease, stroke, type 2 diabetes, breast and colon cancer, depression, and falls. And it's likely to improve sleep, endurance, and sex. I think all of us can, relate to a day when we were extraordinarily physically active, and that night was an especially good night for sleep. Avoiding smoking, practicing healthy alcohol consumption, which means for men to not drink every day, and for men to certainly not drink more than 2 drinks, and for women, not 1. But, there's increasing evidence that there really is no healthy alcohol consumption, that it all has, some risk and maybe not as much benefit as we might have used to thought. Finally, having a relationship with a primary care physician or team is really, really important. And, it is important that, if you have this relationship with somebody and you develop new symptoms or something goes awry, having a physician provider who and who knows you is in the best position to help. And he or she will also be there to help you take action in terms of preventive actions and the screenings that are most important and appropriate to you based on your age, risk, and family history. So what are the basics? I really feel it's very important to have an annual visit with a primary care provider, physician, and we'll talk about who that person is. For the prevention and screening pieces that are tailored to you based on your risk, so key. We talked a little bit about nutrition. We're going to talk about that some more. We'll briefly touch on supplements, activity, and sleep. These are sort of the basics, but increasingly there are some, what I would say are essential extras, which are, the awareness that loneliness is a risk factor for health deterioration. So staying connected with friends and family. That those who practice their faith and for whom faith is important generally might practice healthier behaviors, have stress reduction, and social support from the groups that they worship with. Fun. I don't think fun can be overemphasized. People say to me, "Why did you retire?" And I say that it was to have a different kind of fun than I had in my professional life. The other piece for fun is reducing stress and boosting mood and a stronger immune system. Stress reduction or stress management, you might say, means, practicing self-care and relaxation, those connections, setting realistic goals and challenges, and being open to professional help. I say to patients all the time that we really can't change the stress that we always have to deal with, but we can certainly change how we respond to it. Mindfulness and meditation, I think, are amazing opportunities for people to take advantage of. They reduce stress, improve emotional well-being, and also may improve physical health by lowering blood pressure, improving sleep quality, and a reduction of chronic pain. And then I think we would all recognize that beautiful day that we took a beautiful walk in a beautiful outside space, whether it's a forest or on the beach, and what that did for our mood, stress level, and et cetera. And then the role of awe, in improvements in health. I have a couple of references at the end of our talk, a book that just came out that I think is interesting about some new evidence that a sense of awe and awareness can really improve your health. So those are some of the extras. It's an interesting concept to talk about the 6 pillars of lifestyle medicine, which are really plant-based nutrition, including the Mediterranean diet, physical activity, stress management, avoidance of risky substances, restorative sleep. We could spend a whole hour or more hours speaking about sleep, but sleep is increasingly recognized, non-quality sleep, as having significant impacts on quality of life and risk of chronic medical conditions and the social connections. So you have a PCP, or you're planning on establishing with a PCP. And who is that person? Well, a PCP, or primary care physician, or primary care provider, could be an MD, a DO, or an APC, which is a nurse practitioner or a PA. I would be, remiss if I didn't touch on, the state of healthcare in America and physician shortages. And I think, the bottom line is we don't have enough physicians necessarily to provide primary care, and there's no reason to not include as part of the team or as your primary, a nurse practitioner or PA. This person could be trained in family medicine or internal medicine. And I also, want to mention there may be specialists on the call, that there are sometimes for patients who have chronic illnesses that their specialists may take on a significant role as the primary care physician. And that is very dependent on the person and the specialty. I would say that, that's something that I should do for my patients, but I do have patients for whom their cardiologist or their pulmonary physician or even their gynecologist might be well aware of all the preventive care that they should be getting and can help with that. So why is this so important? Well, we talked a little bit about that relationship. And the relationship, I think, should be enduring and ongoing and cumulative. And there's really been nothing more rewarding for me in my career than to watch people get better or to help them through a difficult time, get to know them. I don't think that, a walk-in urgent care or Google Clinic or one of these standalone places really can replace what a strong primary care physician or team can do for a person. And I hope that that's something that all of you have in place for your own healthcare and your family's healthcare. What about care outside of the visit and the role of patient portals? Well, I'm a huge supporter of patients having full access to all of their clinical information and also having the opportunity to communicate outside of visits to their PCP or team. And I think the patient portal, if used appropriately, both by the patient and with adequate resources in an office setting, can be hugely helpful to get routine advice, to help with care coordination, to share information that, results or new information that a patient may have gotten, care outside of their usual place, and super, super important. And, we can talk some more at the end if people have questions about their use, but I am very supportive. I think the challenge right now for the average American physician is that there's a lot of this messaging that really could be, addressed in conjunction with another team member. You don't need me to tell you where to park for your appointment or to update your chart necessarily with your latest vaccines. So that's been some of the pushback. But there should be this dynamic, interactive communication outside of visits. I'd certainly say, obviously, if you have an acute issue, you shouldn't use the patient portal to message your team or your doctor to tell them that you're having chest pain. Not a good idea. The care coordination piece it's my job as a general internist to pull together all of the information and recommendations from your specialists and from other places you've had care. I may not do that, I may prepare for that before your visit, but that information is coming in all the time. And that's sort of, I don't like to use these analogies, but I guess, you could say coach, quarterback, captain of the ship, whatever one works for you. But that's really what it's about. And then on the annual visit, there are just some things that you can't do via, the portal or even a telemedicine visit. There's a lot that can be accomplished via telemedicine. And I think that it is an important part of visits, and it shouldn't have taken the pandemic to make care more accessible or convenient. But I want to see my patients in person. I want to see how they look. I want to measure and monitor blood pressure, weight, BMI, review new symptoms, update history and family history, and chat about what screening is due and testing are due, and also review results that may have been completed. So for all those reasons, I think an annual visit is important. Now, a lot of times women in particular, they may have an annual visit with their gynecologist. And so as a rule, I have found, not to give the guys a hard time here, but as a rule, I have found that women may be more engaged in their own health. They're certainly maybe more responsible for family members' health. And sometimes the guys need a little pushing. So I would encourage all of you to be established with a primary care physician and to make sure that you do get your annual checkup every year. So let's start talking about prevention. We all need vaccines throughout our lives. Really, there's going to be no year in anybody's life that a vaccine isn't going to be necessary to consider. Every year, we should all get a flu shot. There was just a recent update from the CDC that suggests that people over 65 who have not had a COVID booster in more than 4 months consider getting a booster this spring. RSV is really important, and the RSV vaccine is new and very important and can be given if pregnant during RSV season. And it's something for you to think about and discuss with your physician if you're over 60, particularly if you have health risks like chronic obstructive pulmonary disease or other medical problems. Tdap, tetanus, is with every pregnancy, and a booster every 10 years. And I usually counsel my patients who have small children, who are lucky enough to have small children, infants in their lives, that if you're due for a tetanus, you really should get a Tdap. And you can get a Tdap every 10 years. Most of us have been exposed to measles, mumps, and rubella, already immunized. So that is not generally an issue. Chicken pox for older folks is not an issue, but zoster, or the shingles shot, is very important to be offered at 50, younger if you have chronic medical problems. And it's a 2-shot series, and it gets a little bad press because a lot of times some people might feel a little ill for a day or two. But nobody wants to have the post-shingles pain that can happen, and the shot can be really helpful. The HPV vaccine, or human papillomavirus, is very interesting. It's now offered to all young men and women and men now, and can be given up to age 45 years if it wasn't given. And we know that human papillomavirus is responsible for cancer, not just cervical cancer, but head and neck cancers and other cancers. There's a couple of pneumonia shots that folks should get every year, or I'm sorry, not every year, but either related to chronic illness or at age 65. If you travel and you're not immune to hepatitis A, or you work in food services, you should get it. And hepatitis B, we started immunizing babies in this country for hepatitis B in the 80s. But if you're not immune, and you could be at risk for getting hepatitis B either through an occupational exposure or other behavioral risks, some of you think about. So this is just a kind of a quick conversation about vaccines. Up in the corner of this slide, there's a QR code that if you take a picture of that, it pulls up the CDC site for you. And there's a tool that you can use to figure out what vaccines you might be eligible for. Well, I think now that things have improved in our world a little bit, many of us are traveling again. I know that I am, and I'm very excited about it. So a couple of things to consider is, traveling wisely. There's a great CDC site, I have it listed in the resources below, called TravWow, where you can plug in the dates of your trip and where you're going, and it kind of gives you an awareness of what you should be paying attention to, such as, what are the risks of food or waterborne illnesses, and how do you manage travelers' diarrhea, keeping in mind trauma or injury. Sometimes when people travel, they get a little risky and do things you might not do at home, like ride a motorcycle or jump out of an airplane or something, unusual. The risk of deep vein thrombosis related to sitting for long periods on a long flight. How would you deal with a flare of your chronic medical illnesses? Are you, at risk for an insect-borne infection such as malaria, dengue? What if you get bit by, an otter in Japan? How would you handle that infection or an allergic reaction? And then, other communicable diseases such as risk of sexually transmitted diseases. Sexually transmitted diseases are something that, that I talk about with all my patients, especially the people that I know well, not necessarily just young people. These illnesses are common and can be treated and sometimes prevented. So good resources for travel include the CDC, the World Health Organization, and I would recommend you consider, if you're going someplace particularly exotic or at altitude or in the third world or where you've never been, consider a visit to your PCP or a travel medicine clinic well before your trip, because that's where you can get more, obscure vaccines like yellow fever, or have a conversation about how you're going to manage altitude with medications, et cetera. But don't do it 2 days before. Try to get into that practice or site at least maybe 4 to 6 weeks before. Another important preventive tool that we address very, very, robustly and meticulously with patients is cancer screening. And I'm going to start with cancer screening for a couple of reasons. One is that the March is Colon Cancer Awareness Month, as I understand. And so there's campaigns that are going to be happening in Philadelphia to turn your lights blue and get screened. But it also is two important facts. One is it's probably the second most common cause of cancer death in men and women in the United States. And in some ways, it can be completely preventable. So important. So now we start at 45, maybe earlier based on medical or family history. And people always say, well, what's the best test, Dr. Scoles? What test should I get? And what I would say is the best test for any patient is the one that gets done. Whether it be a fit test, which are those cards that you may have used before, you do that every year, a Cologuard, which you can order and send back in the mail, colonoscopy, or CT colonoscopy. Really, it's best to have a conversation with your clinician to determine the best test for you. And again, it's the one that gets done. If you have a high risk of colon cancer, i.e., the family history, you really need to have a colonoscopy. But if you're low risk or no risk, or it's your first test, you could certainly start with what may seem like a less invasive procedure. But once people get through their first colonoscopy and they deal with the prep and they come out on the other side and all is good, people would probably all agree it's not all that bad. The other thing that you can do at the time, if you have a colonoscopy scheduled, is if you're a patient who's at high risk for Barrett's esophagus, you can also work in an upper endoscopy. And high risk for Barrett's esophagus are men, older patients, smokers, people who have a history of chronic reflux, known prior Barrett's esophagus. And the thing about colon cancer is a colonoscopy is you can screen and intervene by both, seeing the polyps and removing polyps, which are the precancerous cause of cancer. So view and do, screen and intervene. Cervical cancer screening is based on, by age and risk, perhaps every 3 to 5 years. When to start it and when to stop it really is a conversation to have with your gynecologist or primary care physician. And it doesn't mean, though, that you should skip your annual GYN visit, even if you don't need a pap smear every year. That's still a time to review other women's health issues. Breast cancer, mammogram, and now including increasingly conversations to include breast ultrasound for women who have breast dens. So it's a twofer that you have a mammogram every year. And if you have known dense breast tissue, you can include an ultrasound. And that pretty much is covered by insurance. Again, when to start breast cancer screening, i.e. at 40 or 50, and how frequently, every 1 to 2 years, is really individualized and best discussed with your PCP or gynecologist. Prostate cancer screening with the PSA blood test. So there's no consensus on who should get this, how often, when to start. You can, if you look up prostate cancer screening, you see what the American Cancer Society says, what the U.S. Preventive Task Force has to say, but it's really a conversation. Early detection absolutely may improve outcomes for some men, but false positives can lead to unnecessary biopsies and, some side effects. Overdiagnosis and treatment of a slow-growing tumor may be worse than not treating the tumor itself. And best to talk to your team, particularly if you are high risk. For example, you have a first-degree relative, father or brother, who had prostate cancer. In those situations, I often recommend a man, establish a relationship with a urologist early on, say at 40, to talk about, or 50, sometime absolutely before 50, to talk about prostate cancer risk and being screened and followed closely with that kind of family history. So now we're going to get to the nitty-gritty of identifying and managing some chronic disease states. We're going to talk about hypertension, hyperlipidemia, diabetes, cardiovascular disease, depression, briefly, dementia, cognitive decline, and probably the underpinning of most of these chronic problems, and that is obesity. So what is essential or primary hypertension? Essential or primary hypertension is really elevated blood pressure to the degree of greater than 130/90 on multiple readings, especially, particularly you need really more than 3 readings to make the diagnosis. It's estimated that as many as half of American adults have hypertension or high blood pressure. It's a major risk factor for heart disease, stroke, and the leading reason to develop chronic kidney disease and require dialysis or kidney transplant. Hypertension is silent, meaning you can have significantly persistently elevated blood pressures without symptoms. And what's really important, though, is to get an accurate measurement, during your annual or other visit, or learn how to take your blood pressure additionally at home yourself. Ideal blood pressure is 120/80 or less. There may not be a bottom that's too low. If you're a healthy woman and your systolic blood pressure top number is 90 and you're not lightheaded, that may be normal for you. So it's very individualized. But we start getting concerned when blood pressures are consistently greater than, say, 130/90. Not diagnosed with one reading, multiple readings with appropriate equipment. And there is an opportunity to participate in ambulatory blood pressure monitoring, which is where your doctor, cardiologist, or primary care, we give these out all the time, primary care practice would give you a monitor to wear all day long for 24 hours, including during sleep, to see what your real blood pressure is, because sometimes people can very commonly have elevated blood pressures in the office or other settings, which are normal when you are home. We call that white coat hypertension. Sometimes that white coat hypertension, those spikes are still of concern, but the ambulatory blood pressure can often really inform treatment and help make decisions on who should be treated with medication in addition to lifestyle changes. It's another one of those things where losing some weight and eating a healthy diet, particularly one that's controlled for salt, can really get that blood pressure tweaked down a little bit. So how to get your blood pressure checked. So, we'll say this a couple of times tonight, but there are some numbers about your health that are really important to know. Your blood pressure, your body mass index or BMI, your hemoglobin A1C, your LDL cholesterol, your HDL cholesterol. Know your numbers. You might have heard that during campaigns about heart disease. But in the ideal world, with your blood pressure, you would be in the 30 minutes before it was taken. You wouldn't have smoked, you wouldn't have had coffee, and you wouldn't have been running from the train to get to your doctor's appointment on time. Ideally, you'd be sitting for 5 minutes quietly before it's taken. But we all know this realistically. If you've had a doctor's appointment, that never happens, right? You get roomed, you sit down, the MA slaps the cuff on your arm, she's asking you questions. So there's no, in most practices, if it's elevated at 5 minutes, in that you haven't had the 5 minutes, and if it's elevated, it really needs to get taken again. And sometimes we would put patients on intervals where we have you sit quietly in the room and the blood pressure cuff cycles for 3 times, and then oftentimes it's better. I can't emphasize enough, both in an office setting and at home, that you have the right cuff size. And that the majority of the time should be an arm cuff. There's a few commercial home blood pressure cuffs that have a reliable wrist cuff, but most don't. So if you're going to purchase a home blood pressure cuff, I would get an arm cuff. And we can talk in the chat, or I can answer questions about what to get. You want to keep your cuffed arm on a flat surface like a table at heart level. Sit upright with your back supported and feet on the floor. That's the other thing in the exam rooms, right? They stick you up on this high table, your feet are dangling off the floor. It can really interfere with your blood pressure. Don't talk. And after a minute, retake it again. And consider the average of 3. So there's some great graphics on the internet about how to take your blood pressure at home, but this is really the basics are to sit 5 minutes, be quiet, arm at the level of your heart, Make sure the cuff size is not too tight, too small, or too big. If you buy a blood pressure cuff in a pharmacy, the pharmacist can make sure the cuff is right, and a lot of times the online versions can give you some sense about what your upper arm measurement should be. But in the doctor's office, if it's high and they don't check it again, make them check it again in 5 minutes and make sure that they didn't, roll your sleeve up, which can cause back pressure, or that the cuff isn't the wrong size for you. Cardiovascular disease, we're going to talk about that, is a catch-all term for all heart and blood vessel diseases. So it's heart disease and stroke. So common examples are coronary artery disease or ischemic heart disease. Hardening of the arteries is another lay description of it. Heart rhythm disorders or arrhythmias like atrial fibrillation, heart failure due to cardiomyopathy or uncontrolled hypertension. Heart attack or myocardial infarction, which is sudden stopping of blood flow to the heart muscle from plaque rupture or sometimes spasm, which sometimes we see in women. And it is the leading cause of death in women and men too in the United States. And I think, heart disease doesn't always get, particularly with women, the attention it deserves. There's a lot of focus, as there should be, on breast cancer and other cancers, but really the number one reason for any of us in the United States to die, and perhaps die prematurely, is from cardiovascular disease. So we're going to focus a little bit on coronary artery disease. It's the most common type of heart disease. Its leading cause is buildup of plaque inside the coronary arteries. And too much plaque can limit blood flow and cause chest pain or pressure. And this is known as angina. So the typical shoveling snow in the cold, so demands on the heart for increased blood flow or cardiac output related to exercise, exertion, emotional upset, can trigger this kind of chest pain known as angina. And so if you have symptoms above your waist, man, woman, and you're not sure what's going on, reach out for help. Don't assume it's heartburn. Don't assume it's reflux. It can be very, very tricky to sort out. And a lot of times people don't have typical symptoms. I remember a patient vividly, like yesterday, a woman who came in to see me, and she was pointing to her neck and saying, I have this pain here. It's coming and going. It's right here. And we sorted out, and I said, does it hurt when you swallow? No. She says, just my throat, but it comes and goes. And it turned out that she was having, and then she got to, and it seems to be going up into my jaw. It turned out that she was having an acute myocardial infarction basically right in front of me. And it was a very atypical symptom. So it isn't always the typical chest pain. If you have oddball symptoms, shortness of breath, unexplained shortness of breath, unexplained lightheadedness, feeling sweaty out of the blue, things change. If you could previously do fine in your exercise routine, and then all of a sudden now you're getting tired or you're getting more winded, reach out. When plaques rupture is what causes the heart attack, or as I said earlier, sometimes spasm, and we don't really understand why this coronary artery spasm can happen, but it causes the same effect. You get no blood flow to an area of the heart. If it completely ceases, you have a myocardial infarction, very serious problem, life-threatening. Lots of intervention can happen, so get help quickly. So what are the risk factors? One is high cholesterol or hyperlipidemia, particularly high LDL cholesterol. The other is hypertension, particularly uncontrolled, diabetes, having a family history, smoking, including vaping. So nobody who vapes should think that they're off the hook and that's safe. It's really has the same kind of, inflammatory and other, damaging particles as smoking does. Obesity, physical activity, and I think the other piece that perhaps none of us realize or we don't pay enough attention to is the role of inflammation. So obesity is associated with increased inflammation and the likelihood of also having diabetes and high cholesterol and hypertension. So it's sort of like a quadruple whammy. Patients who have chronic inflammatory conditions like rheumatoid arthritis or psoriasis or metabolic syndrome are at much higher risk for coronary artery disease than the average person. So those are subtle things to keep in mind. And gum disease, so chronic periodontal disease, which causes inflammation, can put you at risk for being more likely to have coronary artery disease. So make sure you get to the dentist twice a year and get those teeth cleaned. For many reasons, but particularly for the concern about oral health inflammation. So there's a cool new tool that is called Prevent. And this is an updated cardiovascular risk screening tool. We used to use something called the ASCV risk score that predicted coronary artery risk over 10 years. But in November, the American Heart Association came out with this tool. It's much, much better, much more detailed, and incorporates additional factors and includes predicting risk of both coronary artery disease and heart failure. Which is basically where your heart pumping function fails, and it's a terrible chronic illness to have, and we can identify those patients who might be at risk for that. And this tool is meant for patients without a history of cardiovascular disease. You can get to the tool by going on the American Heart Association website, but I included in this talk the actual link that would take you right out there. So if you copy this and put this in a browser, you would get right to the calculator. And this tool is very helpful because it basically assigns people to risk of heart disease over a 10-year period. So if your risk is less than 5%, generally speaking, we would say, work on your lifestyle and we'll keep an eye on the lipids. The tool includes things like your bad cholesterol, your good cholesterol, your blood pressure, your A1C, even if you're not diabetic, if you're pre-diabetic. And so it can stratify who should be on lipid-lowering drugs like statins or Zetia, or a combination of above to use a lower statin dose. And now there's new non-statin drugs that are known as PCSK9 inhibitors, monoclonal antibodies that are monoclonal antibodies that bind to the receptors and increase the clearance of LDL, and some additional drugs that are sort of investigational. So the days of not being able to treat significantly elevated LDL or known primary coronary disease or secondary coronary disease are over. We have a lot of tools to do that. So you want to risk stratify if you have no disease, and then a decision about, is it lifestyle modification or is it a drug? How much of a drug? Which drug? If you've not been tolerant of statins in the past, there's some tools and there's some new things, drugs that can be used. And then there's the role of coronary artery score testing. So sometimes we have people that are on the sort of in the in-between zone of risk, and we're trying to make informed decisions about being treated with statins. The patient may not want to be on a statin, may have a very low risk overall for heart disease, but their LDL or their cholesterol is super high. So coronary artery calcium score test, which is basically a CAT scan of the chest that looks at calcium in the coronary arteries, the hard plaque that's there, which can be sort of an indicator that there's soft plaque that could rupture. If your calcium score is 0 and you're not on a statin and your overall risk is low, you might not be somebody even with super high cholesterol that should be on a statin. if your calcium score is anything more than 0, what that means is that you do have some coronary artery disease, and that's where the conversation has to happen about what drug and starting it and monitoring it. So this new tool is really helpful because the other cool thing about the tool is that it also incorporates a patient's zip code in terms of, those factors that we can't measure that put your health at risk. The neighborhood you grow up in, a lot of times that is more predictive of your longevity than anything else, the zip code that you live in. So diabetes and prediabetes, we are all at risk for developing type 2 diabetes as we get older. So that's the kind of diabetes where your body makes insulin, but as time goes by, we become resistant to the insulin our body uses. It's a chronic condition that affects how our bodies regulate blood glucose or sugar. The risk increases with a positive family history or history of gestational diabetes during the pregnancy. Diagnosed by blood tests, fasting glucose, or, more frequently a hemoglobin A1C test done based on a schedule, based on your risk factors, your family history, a conversation with your doctor. Most adults, particularly if they're overweight, should have an A1C, 35, 40, and then decisions about how frequently to follow. So this type of diabetes is characterized by insulin resistance, which occurs secondary to being overweight or obese. Having prediabetes, which is an A1C between 5.7, say, and 6.4, some of this is dependent on lab, does increase your risk of developing diabetes, but it's not inevitably. 5 to 10% of patients will go on with prediabetes will go on to develop type 2 diabetes, but lifestyle changes, even moderate weight loss, like 5% of your body weight, can significantly reduce your risk of going on to develop diabetes. So why is it so important to prevent it or identify diabetes, or most importantly, to control it if you do have it? Well, patients with uncontrolled diabetes are at a much higher risk of cardiovascular disease and stroke. Diabetes is the leading cause of blindness due to retinal disease, the leading cause of kidney failure leading to the need for dialysis or kidney transplant, with uncontrolled hypertension accounting for over 75% of new cases of kidney failure annually in the US. It's increased risk for lower limb amputation. And really, there's quality of life issues can't be underestimated in terms of having chronic neuropathic pain from diabetes and associated, complications such as impotence. It is, uncontrolled diabetes, complicated uncontrolled diabetes is a terrible, terrible illness. And, it's so impactful on patients' quality of lives and risk of other medical problems. I can't stress enough the role of mental health, depression, and anxiety. There's no question. I know Camelia told me that you guys have had talks about mental health, but we try hard in primary care to absolutely identify patients at risk for suicide, to get them identified, treated, to work on quality of life, and helping to improve management of other chronic illnesses. I can't stress enough that if someone's depressed, nothing else is going to go well. It's so difficult to get healthy and stay healthy, and it's a terrible barrier. And it's important to keep in mind that there are some chronic medical illnesses that can present as depression. Things like newly undiagnosed uncontrolled diabetes or an underactive thyroid, or other endocrine issues. So we have to be really careful to sort out what the issue is and get it addressed. And in my practice at Jefferson, I was really fortunate because we had embedded behavioral health specialists that could, help us manage patients and assist with referrals, which are so difficult right now with getting patients in to see a psychologist or a therapist or psychiatrist. And we also had an embedded pharmacist to help with medication management. So very fortunate to have that kind of team. Cognitive impairment and dementia is something I think we all worry about as we get older. I certainly think about it, and we all know somebody who has had their quality of life, affected, either as being a caregiver or watching a loved one experience this. But you can reduce your risk of some forms of dementia and cognitive impairment because there is certainly a vascular basis, and doing things like, maintaining a healthy diet and being active, challenging your mind, and controlling chronic conditions as well as staying socially connected can help. And we don't have the time today to go through, the types of dementia and what can happen. But there are centers at any of the major universities where you can get involved in screening and participating in, what's new. There are some drugs that are being developed. I don't know how helpful they're going to be, but this is something. It's not another one of these inevitable paths necessarily. All right, so what's the cause of all our trouble in terms of chronic problems? Well, I think among the most significant risk factors for everything we've talked about is obesity. The other thing that we don't always think about in terms of obesity, we think about diabetes and heart disease and stroke, but things like cognitive decline or cancer risk in patients who are overweight, or the effect of lifestyle limitations due to terrible musculoskeletal disease and early need for joint replacement. It's all so important. So global epidemic, it's estimated that, more than 2/3 of Americans are overweight or obese, and clearly eating less and moving more, that ship has sailed. That is helpful, but not the answer for most people. And the sneaky thing is that the human body has a set point, and I'm sure we've all experienced losing that 5 pounds and then having it creep back up again, or how hard it is, especially later in life. So there's roles for newer drugs and surgery for patients, and you've all heard of Ozempic and Wegovy, which is semaglutide, and the newest drug is Zepbound or tirzepatide, which is a combo of the GLP-1s, which are Ozempic and Wegovy, and a GIP drug, which may be the most important effective drug to date. There are studies underway about additional cardiovascular benefits in the development of drug schedules longer than once a day or once a week, i.e. maybe twice a year. I saw some post somewhere about these drugs being given like vaccines to prevent obesity or health. And again, this is another example, I think, of where an individualized multidisciplinary approach can be really helpful. Nutritionist, a primary care physician, bariatric specialist, and some patients, really do benefit as well. Many patients from obesity surgery. So it's very, very much a multidisciplinary approach. We use BMI to kind of risk stratify patients. Patients who have a body mass index over 30 are eligible for drugs, may be eligible for surgery. Lower BMI, say 27 to 30, but chronic medical problem like high cholesterol or diabetes also may be eligible. But I would remind everybody that even losing as little as 5 to 10% of excess weight can really help with improvements in lowering your risk, low blood pressure and low blood sugar. And we'll talk a little bit about activity, but you have to eat a healthy diet. Just like cholesterol drugs, you can't take Crestor and then eat a cheesesteak every day. I mean, that's counterproductive. And so it really is a threefold approach. So we talked a little bit about the Mediterranean diet earlier. I really feel strongly that Mediterranean diets and plant-based diets are so helpful, and eating food that a great grandparent would recognize as whole food. Consider working with a nutritionist. Supplements are often sort of, touted as being important for disease management, but evidence is limited. So clearly we know folic acid supplements are essential to reduce the risk of birth defects. So even pre-pregnancy, you recommend women start them. If you take certain conditions like metformin, you might get a low B12 level. So certain medications or dietary preferences, if you're a vegetarian or you have celiac disease, you may need supplements. Best to get adequate calcium from your diet. Best to discuss with your PCP or therapist or nutritionist. Keep in mind that these things are not regulated and interactions can occur. And always, when you're providing a medication list to your physicians, always list these supplements that you're taking, because they can absolutely impact drug interactions, need to be held before procedures sometimes, can cause bleeding risks, etc. Always important. Protein. So we're talking about nutrition. We don't eat enough protein, I would say, many of us. And the downside of that is you feel hungry all the time. You don't have the energy that you need to be active. So the recommendations are that we eat 0.8 grams of protein per kilogram of body weight, and that if you're regularly actively exercising, you increase it. So lean animal protein is best. If you don't eat animal products, then Greek yogurt, plant-based protein. An egg a day is probably okay unless you have high cholesterol, you've been told not to eat them. Meat. One switch that I think is really helpful is to switch out rice for farro. It has 4 times the protein and it has some additional fiber. Don't forget about chickpeas, beans, nuts, seeds, protein powder in a smoothie. And there was a recent NPR segment, which was very interesting. Millions of women are under-muscled and don't get enough protein. So I love this quote. We don't stop playing because we grow old. We grow old because we stop playing. So I always tell the story that the best thing that ever happened to me in my life was when I was in high school and I tried out for the cheerleader or flag twirler squad and I didn't make it. I got cut. And at the time I was devastated because I really wanted to wear that cute uniform and go to all the football games and do that. And looking back, I was probably because I was too chubby for 1970s standards, but be it as it may, instead, I started playing tennis. And I don't know about you, but I haven't seen too many 67-year-old flag twirlers lately. But there's a lot of us who play tennis. And I've been playing tennis with a core group of women since 1988 on Saturday morning. And I think that's kept me happy and healthy. And there's nothing like hitting that little ball. Hi, Camille, you have a question? Oh, okay. Gotcha. All right. So activity, critical to getting and staying healthy. So my recommendation is that you find a way to make it automatic or schedule it like any other important event or meeting or commitment, and don't skip it. And commit to small goals. If you're not feeling like you're active enough right now, make a commitment to yourself. Okay, I'm going to walk a half an hour on Monday, Wednesday, Fridays. And then next week, I'm going to walk every day. And give yourself some grace and don't be hard on yourself. And I think it's really important to remember how you feel when you're done. So remember the last time you moved and did something like a long walk or swam or ran or rode or, even, anything, danced, and remember that feeling when you're done. And that's where you want to start. And don't go to too hard. Find something fun that you can stick to. And the important stuff is it's not just, physical health improvement, but it really can help with mood. So helpful. And, we used to say aim for 150 minutes a week, but it's interesting. There's new data that suggests that women might shorten that, and that men actually need more, because these numbers were averaged, to see a reduced risk of death. And then to find other ways to move as much as you can. All the things we talk about, parking farther if it's safe, taking the stairs, getting up, having your smartwatch remind you that you haven't gotten out of the chair. And to keep in mind that flexibility, aerobic fitness, muscular strength, and balance are all important. And you can do different things to achieve that. So the other thing I really want to stress is the role of strength training. I think that everybody is, starts to count steps and time on the treadmill and walking, but if you incorporate some strength training once or twice a week, it can really go a long way in, strengthening your bones and muscles, perhaps reducing your fall risk, preventing or improving osteoporosis. And the other thing is that it's the secret sauce of losing weight in midlife. Because if you just do your cardio, you're going to be frustrated. But if you throw in a little strength training, not to bulk up, but just enough to whether using body weight exercises or free weight exercises or bands or weight machines a couple times a week, that is a significant metabolic booster, because muscle is more active and requires more. And I've always found that if I slack off on the strength training, there goes those 5 pounds again. Like, where do they come from? I didn't change what I ate. I'm still running around on the tennis court, but I dropped the strength training for whatever reason. And don't forget about yoga or Pilates for balance and flexibility. So we're almost at the end of our talk. And I love this quote from Margaret Mead, that it's utterly false and cruelly arbitrary to put all the play and learning in the childhood, all the work into middle age, and all the regret into old age. So let's roll back the clock. Let's have no regrets. Let's play now, and work as much as we have to or want to. For some people, their profession is all play, and that's wonderful and all fun, but let's keep these other things in mind. And here are some resources. American Heart Association. I think if you have any chronic medical problems, your best place is the association, for your condition. So whether it's American Heart Association, American Diabetes Association, there's a osteoporosis organization, American, the Arthritis Foundation. I like the Medline Plus site for good, valid health information, the CDC. I think the Harvard Health Watch resources are excellent. There's a couple of books that I've read recently that were interesting. One is The Power of Fun, How to Feel Alive Again, by the woman who wrote How to Break Up with Your Phone, and Awe, the new science of everyday wonder and how it can transform life. And Hello Sleep, which talks about, overcoming insomnia without medications. Certainly, insomnia, you could have sleep apnea, make sure that gets diagnosed. And I thank you.